How's it going, guys? We have a medium difficulty question for hematology. 12-year-old girl brought in for a follow-up appointment. Father, 49 years old. He has history of splenectomy, cholecystectomy 20 years ago for an anemia, in quotes. She is asymptomatic. Her vitals are normal. We have this image here of spherocytes, which USMLE will show you. They're very robust and full in color. They lack any degree of central pallor. Normal RBCs will have mild central pallor. If you have iron deficiency anemia, they'll be basically clear. They'll be very, very hollow, translucent / transparent in appearance. Okay, but these are very robust. These are spherocytes. Now, the reason that you get history of splenectomy, cholecystectomy, first of all, it's an autosomal dominant condition, and USMLE will give you a kid with a parent in this structure of a question. Now what's going to happen is the RBCs that are abnormally shaped are going to be filtered out by the red pulp of the spleen, and this is going to cause an unconjugated, indirect hyperbilirubinemia. This bilirubin is going to go to the liver, and it's ultimately going to get conjugated, and then it's going to end up as pigment stone cholelithiasis. And for TCK3, they can have cholecystectomy plus splenectomy as a combined answer. It's very buzzy in a question, though, even for step 1 level, that if they tell you there's a parent who had history of splenectomy and or cholecystectomy, they're handing you the diagnosis of hereditary spherocytosis. So choice A is wrong, direct bilirubin 2.4. You say, well, I don't know the normal ranges. That's fine. Total bilirubin should be around 1, and direct bilirubin should be around 0.1. Most of it should be indirect, about 0.9 of it. But regardless, with the direct bilirubin 2.4, very, very high for direct. Okay, direct shouldn't be elevated, at least appreciably, in increased RBC turnover. I'd say 7 out of 8 questions on USMLE when you have a situation with increased RBC turnover, sickle cell, hereditary spherocytosis, someone gets many packs of RBCs during surgery, and they end up getting a jaundice. 7 out of 8 questions, it's going to be very high indirect, and direct won't be elevated. I've seen maybe one question where direct was questionably increased, but you could still infer that it was increased RBC turnover. Okay, so wrong fucking answer. Choice B, homozygous mutations, wrong. So it's autosomal dominant heterozygous mutation, anchor and spectrin band proteins, RBC cytoskeletal / cell membrane proteins. Now, USMLE will ask this. They'll have different combinations. They'll have homozygous ankyrin, heterozygous ankyrin. Okay, and it would be heterozygous ankyrin. Or separately, they could have a different question where the answer is heterozygous spectrin, heterozygous band protein. Okay, vast majority of conditions that are autosomal dominant are going to be heterozygous. Okay, whereas homozygous tends to be autosomal recessive conditions most of the time for genetics. Wrong fucking answer. Choice C, MCV of 98, correct answer. So normal MCV, mean corpuscular volume, 80 to 100 femtoliters. And hereditary spherocytosis is a normochromic normocytic anemia. You say, well, the RBCs are very robust and full in color, as you just mentioned. They're not hyperchromic. They're not. They're still described as normochromic, and it's normocytic, 80 to 100. They asked this on the NBME for step 1. They'll literally have all the different combinations, hypo, hyper, normo, okay, micro, macro, all that. And it's normochromic normocytic. Okay, so it's a little bit tricky. Maybe it's a difficult question for most of you. Okay, but you can eliminate the other answers here. So it's a normochromic normocytic anemia, as we have here. Choice D, positive direct antiglobulin test. It's one of the ways USMLE can write Coombs test. There's different types of Coombs tests. You can have an indirect one as well. I don't want to obsess over the mechanism of how the Coombs test is performed and all that. That's actually very unimportant for USMLE most of the time, okay? This is what you need to know. A Coombs test, aka direct or indirect antiglobulin test, simply means, do we have antibodies against RBCs, yes or no? And I'm asking you watching this clip, do we have antibodies against RBCs in hereditary spherocytosis? Obviously not. It has nothing to do with antibodies. Isn't it just anchor and spectrin band protein mutation, heterozygous autosomal dominant, as we talked about? So you have a negative Coombs test. So the relevance of this answer choice for USMLE is that you can sometimes get spherocytes with autoimmune hemolytic anemia, sometimes with viral infections, sometimes autoimmune diseases like SLE, you get antibodies against your RBCs. Okay, sometimes drugs can cause it, and you would have a positive Coombs test in that setting. So if they said 12-year-old was given a sulfate agent, nothing to do with G6P deficiency, just random autoimmune reaction, and there's spherocytes present, positive Coombs test, hereditary spherocytosis is wrong. The answer is just autoimmune hemolytic anemia. Choice D, wrong fucking answer. Choice C, reduced MCHC, wrong answer. Okay, so MCHC can be increased in hereditary spherocytosis. It's not specific for it, okay? It can sometimes be elevated in other random conditions. It's more just that if you were to get a question like this and they happen to list a few labs and they say MCHC is high, you're like, boom, easy, pass level, hereditary spherocytosis. So sometimes it's thrown into questions for hereditary spherocytosis and it gives it away. Okay, just something about the abnormally shaped spherocytes result in the concentration, quote unquote, of hemoglobin within the RBC to be slightly higher compared to normal by concave disc shaped RBCs. Wrong fucking answer.